Good afternoon. Today is August the 14th, 2024, and it is 4:02 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Strategic Planning Committee. As a reminder, a committee member may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. I would like to also announce that the public hearing to discuss the proposed Central Health Fiscal Year 2025 budget and its associated tax rate will take place at 5:30 p.m. So, our first item of business is public communication. Members of the public who wish to make comments virtually during the public communications portion of the meeting must have registered with Central Health via the online form or by telephone no later than 2:30 p.m. today. Has anyone registered to make comments for the Strategic Planning Committee meeting? No, no one has scheduled. Oh, hi.
Madam Chair,
Yes.
Brinson.
Yes.
I called and signed up to speak in citizens communication, but I'd prefer to speak right before the public hearing.
Okay.
Thank you.
All right.
I'm sorry, I apologize. I told Brianna that I was going to signing up for citizens communication.
All right, so we will now proceed to the committee agenda. Number 1, review and approve the minutes of the June 12th, 2024 Strategic Planning Committee meeting. Would anyone like to? Yes, thank you.
I move that the committee approve the minutes for the June 12th, 2024 Strategic Planning Committee meeting.
Thank you. And a second?
I'll second.
Oh, yes. All right. Manager Jones, thank you. Number 2. Oh, a vote, please. Yes. Can we vote? Everybody approve? Say aye. Yeah. Okay.
Elisa's on the.
Oh, and Elisa. Thank you. Thank you, Elisa. Yeah, gotcha. Thank you. Number 2. Receive and discuss an update on Central Health communications, engagement, and outreach efforts, including efforts regarding FY 2025 budget and strategic priorities. Ivan Davila, Isela Guerrera, Ida Serta Prazik, and Yesenia Ramos will be presenting.
Good afternoon. My name is Ivan Davila, and I'm the Senior Director of Marketing and Communications here at Central Health. And like we do every year leading up to the board's approval of the next fiscal year's budget, we are sharing with you today our community engagement and outreach efforts for fiscal year 2024 to date. Next slide, please. So community outreach is embedded in our system's DNA and operations. From the moment our team members encounter a potential patient to the moment that that patient enters our care to when they transition back to the home from the hospital, for example, our team members are there offering support, education, and resources every step of the way. What you see on this slide is just a brief snapshot of our system-wide outreach and operation strategies. This slide only scratches the surface of the work our teams across the system do daily to connect with our community in meaningful ways. During this presentation, however, we are focusing on the efforts of the Central Health Community Engagement and Outreach team. And while these efforts are key components of our system, it is important to understand that they are part of a much larger integrated approach to care. Next slide, please. So I am so deeply honored to introduce to you guys the heart and soul of the communications dream team, specifically our engagement and outreach team. These individuals here are not just communicators, they are the bridge builders who connect us to the communities that we serve. Their work goes far beyond traditional outreach. They are the voices that amplify our mission, ensuring that every message resonates with every member of our community, particularly our patients. Through their tireless efforts, they have touched lives in ways that numbers alone cannot capture. They bring warmth, empathy, and an unwavering commitment to every interaction, making sure that every person feels seen, heard, and valued. So please help me give a warm welcome to the members of the Community Outreach and Engagement team. And they're going to say a little bit about themselves.
Okay. Hi, I'm Aida Cerda Prajak. I am the Community Outreach Supervisor. I love my job. My job gives me purpose, but more importantly, it enables me to help our community build capacity so that they know how to access resources. You know, they say give a person a fish and they eat for a day. Teach them how to fish and they eat for a lifetime. We're teaching people how to fish.
And hello. Is this okay? All right, perfect. All right, so I don't believe the board fully knows this about me, and hi, again, my name is Yesenia Ramos, Community Engagement Supervisor. I am a social worker. My background has always been rooted in nonprofit and grassroots work. My previous roles here in Austin as a case manager, community school coordinator, and a director of a family resource center have allowed me to make a significant impact in my community. But however, my position here at Central Health has provided me with this unique opportunity to elevate the voices of my community and drive meaningful change within the healthcare space on a much larger scale. And that's why I enjoy what I do.
Can you hear me? Good afternoon. My name is Blanca Gonzalez, and I'm a community outreach specialist. It has always been in my nature to help others. So being out in the community and seeing the impact and the benefits of us being out there brings me so much joy and eagerness to continue doing what I love.
Hi, my name is Cassie Gallardo. I'm part of the communication outreach team. Having the privilege to start at the call center, I had the opportunity to hear many stories that I was able to relate and empathize with. Also understanding the need that was needed in our community. Being able to be a source to our clients not only helps better our healthcare system, but also helps better our clients' health.
Okay.
Hello, good afternoon. My name is Isela Guerra. I am the Community Outreach and Engagement Manager at Central Health. I am a native Austinite. I've been at Central Health for over 15 years. I've had family members on MAP before I even knew what that was, before Central Health was even in existence. Part of the reason that I love what I do and that I've been here for as long as I have been is that I truly just love helping people, and especially with something so personal like healthcare. I also love building the relationships that help to strengthen that safety net for our members when they need a resource outside of healthcare. You know, we're working to make partnerships with other organizations to be able to hand them over to that resource. And finally, I love seeing people who are empowered to care for their own healthcare and are empowered to use their voice to make an impact in how that healthcare is delivered. Thanks.
Christian Nelson is our Communications and Community Engagement Program Manager who couldn't be here. He manages our Community Health Champions program, and he sends his regrets for not being able to be here. Also, as a large extension of our outreach and engagement team are our partners at Community Coalition for Health. What you're going to be hearing today encompasses this team's effort, as well as Community Coalition for Health's efforts, who really build capacity for our team. And so next, I'm going to turn it over to Isela.
Thank you. So just as a quick reminder, outreach is usually a one-way communication channel that informs our audience about an issue, a problem, or an opportunity. So in outreach, it's about educating and connecting people to the programs that they need and the services that they will utilize. Next slide, please. Okay. Our objectives in outreach, starting with the very first one, are directly tied to our healthcare equity plans, members' engagement and enrollment strategic imperative. We want to empower our members to participate in our programming across all areas, from health and wellness activities to advocacy and involvement with our process. Our second objective is about informing people living at or below 200% of FPL that low-cost and high-quality healthcare is accessible to them or someone they know. And the third objective is where we connect residents to the coverage, care, and opportunities to get involved that are available throughout Central Health and our system. Next slide, please. So our priority populations are many. Of course, Travis County residents living at or below 200% FPL in general. But we focus on reaching these populations not only through a robust paid media and social media plan that our department executes, but some of these communities here are best reached through grassroots outreach and word of mouth. So for example, people experiencing homelessness, justice-involved individuals, people without access to the internet. A lot of times, we're seeing them in person, and so, we want to make sure that we have both the media and the face-to-face grassroots outreach. Next slide, please. Okay. Aida will talk about some of the tactics that we use.
Here we go. Tactics. Faith centers, very important in our community. We do MAP outreach at churches who feed the unhoused. We help the patrons renew their MAP card, get MAP for the first time. We print out their cards, and we print out the documents that have gotten lost or stolen. Apartment and mobile home communities. Our outreach partners, Community Coalition for Health, they help us reach low-income people in apartments and mobile home communities by canvassing in these areas. They're an extension of our team. Employment and resource fairs. Our outreach team attends many employment and resource fairs, including those focusing on the reentry population. Food distribution events. People experiencing food insecurity also need health coverage and other resources, and we're there to help connect them. I'll turn it back over to Isela.
Thank you. So based on our demographic reports, these communities here on your, what is that, right? These communities have lower than projected enrollment, meaning that these areas have the greatest counts of residents living with low income who are not enrolled in a Central Health program. So we see a lot of opportunity there to connect people to coverage and care. So we try to focus where we know the need is great. Next slide, please. Okay. Another tactic we utilize is our partnerships with our network providers. Here on this map, you can see how by us sharing our information and updates with them, they are an extension that help amplify our message to parts of the county and beyond that we're not always in. So that really does help us reach more people. Next slide.
One more thing to note there. You'll also see in your packet a longer list of organizations that we share information with. It is a long list, but if you think of an organization that you don't see on this list, please share them with Brianna, and we're always happy to add more organizations to our contact list to share more information and broaden our reach.
All right, as you can see, we had a 201% increase in MAP applications from between 2023 and 2024. That is largely due to our increase in MAP assistance events. We've more than doubled our locations where we help people enroll in MAP. That's a 125% increase. We also had a 16% increase in the events that we attend. Those are resource fairs, pop-up resource clinics for the unhoused, employment fairs for the reentry population, and also our partners, Community Coalition for Health. They've enabled us to increase our reach in the community. So overall, we increased the number of people reached by 26%. Next slide. All right, what you see on the screen is just one of the many stories we hear every time we go out in the community. Next slide. All right, so these are just some of our partners that you see here. A longer list is in your packet. Some organizations serve the unhoused, the justice involved, and low-income community members. Central Health also hosts a monthly community outreach leaders meeting once a month via Zoom. These are staff members of organizations that serve the same populations that we do. We regularly have 50 people on our Zoom call, and we are constantly recruiting from the longer list of community partners in your packet. In the year and a half that we've been doing this meeting, we've increased the attendance from about 24 regular attendees to over 50 every month. Even July the 3rd, the day before a holiday, we had people call in from vacation. They were out of state, but they wanted to call in and just participate in our meeting. Now, on the left, you'll see, you'll find organizations with whom we've partnered for enrollment events, and we're constantly recruiting from organizations. On the right, you'll see the organizations that attend our monthly outreach leaders meeting. Next slide. So, I spoke earlier about the heartwarming stories that we hear every time we go out in the community. This particular gentleman who was at the Terrazas Library for assistance was relaying to one of our CHWs that having that map card enabled him to get a tablet. It also got him primary care, and he got a voucher for a vision, for glasses. Just having that map card is a lifeline to our community. It connects them to resources. It's just, yeah, there's a lot of gratitude out there in the community. Okay, next slide.
Okay, thank you, Aida. So now on to our community engagement activities. Engagement differs from outreach in that it emphasizes active participation and collaboration rather than just sharing information. It's more of a two-way dialogue. For our engaged patients, MAP members, and stakeholders, we deepen their understanding of Central Health so they can not only advocate for themselves and others, but also so that they can contribute in a meaningful way. Next slide. Okay. Our primary objectives of community engagement here on screen. Number one is to actively involve Travis County residents in Central Health's public engagement opportunities. And two, to deepen understanding of Central Health's programs, services, and the value it brings to our Travis County residents. Next slide, please. Okay, here I'll hand it over to my colleague Yesenia.
Thank you, Isela. So this year, like other years, our team organized various programs and events to engage our community. This included community conversations where we gathered input on important topics such as the Central Health CEO search, our healthcare equity plan, and our fiscal year 2025 budget priorities. This year, however, we really made an effort to ensure board members were present at these events. And so we want to thank each of you for your time and commitment to our communities, for joining those important work sessions. As we're making significant changes to our website pages, as Central Health increases medical services, we also wanted to be sure to receive feedback from community members, especially MAP and MAP Basic members on our website. So we did so by creating a website study survey. And all of the numbers are on this board and on your board packets. We also graduated our Community Health Champions Fall cohort and our Spring Neighborhood-based cohort. These are members who are interested in learning and growing their knowledge and network in the healthcare field and are challenged to think outside of their individual realities to become advocates for healthcare access and equity in their own communities. This neighborhood specifically was in the St. John and Runberg communities. We also hosted involvement initiatives, which included events like the roundtable discussions with Pat and our community leaders in various advocacy spaces, and lunch and learns to keep the community informed and involved about the work that Central Health is doing. Also, this number isn't on here, but we did host a lunch and learn yesterday. We had 68 participants attend virtually via Zoom. The video is available, however, on YouTube for anybody to watch. It's available in English and in Spanish. We did host that event in both languages. And also about this lunch and learn, the topic was on our medical respite program. It's amazing if you didn't get a chance to tune in. I think I saw Manager Jones tune in to the Zoom meeting. Please feel free to go in and listen. Lots of really, really great work on our medical respite program. And I really, really like that we have broadened it to our larger community. This was a recommendation made by community members at the community conversations. As many of you know, these lunch and learns were originally just for our community health champions, but we have expanded it, and overall, really, really great turnout on those. We also were able to give CHWs, community health workers, an opportunity to earn CEUs by attending that lunch and learn. There's also a memo in your board packets that talks about our 3 advisory committees for the future Latino Family Support Conference. These numbers on the screen are including only the external and the patient advisory committees. All of these numbers do not include staff numbers. So although we do have staff that have joined the CEO search or an internal staff advisory committee meeting for that Latino Family Support Conference, these numbers only include community member numbers. We also have the internal advisory committee in addition to. That consists of our enterprise partners. So we have representatives from Central Health, Community Care, and Sendero. And also the new Art Curatorial Committee, which was mostly made up of health champions, are members of our community who are involved in the art space, but who are helping us kind of curate a calm and welcoming environment for our patients throughout our upcoming facilities. And I think many of you have already seen the artwork at the Rosewood Zaragoza Specialty Clinic. That was in large part due to this Art Curatorial Advisory Committee, and more to come on that. Next slide, please. All right, here's 2 photos from 2 of the community conversations that we had. On the left is the one we hosted at the Southeast Health and Wellness Center on our healthcare equity plan. The one on the right was at the City of Austin Permitting and Development Center in ACC Highland area. An attendee who had previously, and we put the quote on the top, who had previously spoken at one of our public communication Board of Managers meetings, did commend us for following up after speaking at the board meeting. We do follow up with people that come and speak. We do invite them to future events, and we want to keep members of our community that are very passionate about helping our community and advancing our healthcare spaces. We want to keep them involved, and so that is one of the ways that we do that. Once someone is engaged with us for the first time, we move them over to our actively engaged tag list so they can receive our monthly updates via our newsletter. And for example, today's public hearing was not only shared on our social media posts, Facebook, Instagram, but it was also shared via that monthly newsletter. And next slide. Here are some demographics. So this does not conclude the entire fiscal year. We still have 2 months remaining to add to our final engagement numbers. But these are people who are involved and engaged and self-disclosed their demographics at events. We do not require that they fill out all of the necessary, all our necessary information if they do not want to fill it out. And so all of these demographics are optional when people come to our events. These include patients, advocates, community partners. There is a balanced representation across different age groups. There is a significant participation from residents age 45 to 64. We had participation from various racial and ethnic backgrounds and gender identities, ensuring that the community engagement efforts are inclusive and representative of the populations that we serve. I want to highlight that these percentages include all stakeholders. These numbers are close to representative of our patient population. And there's a continued on the next slide. And also for HIPAA compliance reasons, we're not able to gather health coverage status. But as stated earlier, we are hosting these engagement efforts in neighborhoods with higher concentrations of poverty. And next slide. As of right now, as of today, our Community Health Champions alumni network is up to 379 and growing. And we have lots of really dedicated and motivated advocates as part of these this network of community health champions. We are also excited to announce that for this upcoming fall cohort, we have 50 community health champions that have accepted our acceptance letters. And so we're really excited, and we will have biographies for them coming up. And our program actually starts September 5th. So we're really excited for that. The healthcare equity training and workshop 1 will be the first thing that our community health champions learn, and that will be held at the Southeast Health and Wellness Center, which is also in this picture from this past year. Next slide, please. And this is a photo of our community health champions in the Runberg St. John area. The amount of community involvement in St. John Runberg areas is in large part because of our outreach partners at AISD and Austin Voices. They really helped us get the word out to a lot of the community members and parents that are involved in those 2 communities. We did attempt to pilot 2 cohorts in Colony Park, 1 in English and 1 in Spanish. Our recruitment efforts included door-to-door hangers, conversations with neighbors, partnering with local resources like Equidad, ATX, and reaching out to the Colony Park Neighborhood Association. Although we did not have enough people interested in the English or Spanish cohorts this time around, once we have an established Colony Park Health and Wellness Center in the area, we do plan to restart these efforts. And several community members in the Dove Springs area have expressed interest in bringing a cohort to the Dove Springs community. So we will be starting the planning process for that area for the spring. Please keep in mind that these are deep engagement efforts. However, in these neighborhoods, we are still in these neighborhoods with our outreach efforts. And next slide, please. And this is Francisco Navarro. So he was part of our Community Health Champions Runberg/St. John cohort. We met him while promoting for the Community Health Champions program, and he told us that this was the first time that he's ever been involved in anything like this. So he was really excited about it, and he did tell us that he is eager to learn more about how he can get the message out to his friends, families, neighbors in his community and get them involved as well. He is also now part of our advisory committee for the Latino Family Support Conference. So y'all might meet him pretty soon, but he is very, very involved and eager to assist in any way. And let me see. And I believe that is it for us. We want to thank you all for your time, and thank you so much.
Thank you so much. Does anyone have any questions? Yes, Manager Jones?
Excuse me, first of all, thank you so very much for what you do. You really do a fantastic job. I've talked to many people in the community who are familiar with the work that you do, so I want to commend you on the great work you're doing. My question goes primarily, when I look at these demographics and when I look at our community, my sense is, and correct me if I'm wrong, is that we do a great job around the corridors of I-35, Runberg, St. John's, down in Del Valley, and maybe Dove Springs. You mentioned that we're trying to do some things out in Northeast Colony Park. There's also the community of Manor out there, and there's also the community of parts of Elgin that's in Travis County now, and other pockets along Blake Manor Road and the like. Many of those populations are African Americans. So my question goes to the fact that I believe in diversity and the like, but where are we in trying to encourage and recruit for staffing purposes as well as for outreach for African Americans to be able to help us with outreach? I saw Chris Nelson, and I assume he's working with you, and I see some of the champions, but are there other efforts that are underway to specifically focus in on the African American population in outreach? That's the first question. And the second one relates to marketing versus outreach.
So yes, Christian is part of our team, and he couldn't be here today. And also, we rely on the support from partners who or vendors who help us extend our outreach team efforts. So we're constantly working with vendors to help us reach communities that we or that our team isn't able to reach. The Manor, Northeast and Manor and Northeast Travis County, those are part of our key areas where our outreach team is working, and they are on the ground in partnership with Community Coalition for Health in those communities, including Manor. Yeah.
Okay, C2H, that's a community coalition. So is our plan in FY25 to continue to use contractors such as C2H and others in those areas?
That's correct. We will continue to use contractors.
Okay, and do we have outreach workers on the ground? Or do you have the numbers of those who are African American?
We can get that number for you.
Okay, yeah, I'd appreciate that very much, because in communities like, not necessarily Colony Park, but Lakeside, which is a really underserved community, which a lot of challenges, which is primarily African American, even though it's a mixture. When I go out and I talk to people, I'm not hearing the same message. I'm not saying it's not being done. I'm just saying I'm not hearing that message. So I very much encourage you to look at specifically at those communities I mentioned, because when you look at the data in terms of mortality, and most of those folks are 200% of poverty or above, or below, their African American population.
Okay.
So I think
that's helpful feedback. So we will be touching base with our partners, with our contractors, to make sure that we are, and we constantly get updates from them. We meet with them on a weekly basis. Our team does, and they are in that specific neighborhood.
Okay. Well, that's good to know, but I'd be interested in getting feedback.
Thank
The last question relates to marketing versus outreach. When we say outreach, I think, and forgive me, I'm old school, I was born back in the 50s, so we see something differently. But I see outreach as actually going in, knocking on the door, going in apartments, where it's safe, of course, and doing detailed analysis of what's going on in that household, beyond just getting them enrolled in MAP and other things. Marketing this is what we do. We're Central Health. We're the healthcare agency for Travis County. I'm trying to see, is there a different approach? Do we have different strategies in terms of doing those things? And do you all do both, or do we have another group that does marketing?
This team is specifically outreach and engagement. We have several other team members that specialize in content creative, which is part of marketing. So yeah, the answer to your question is yes and both. But this team is specifically geared towards outreach and engagement, and this report is specifically for outreach and engagement. But we'll come back with more information on marketing.
Okay, but this is a group that goes out to the neighborhoods.
That's correct.
Knock on the doors, get the information, and so I'd just be interested in more, what other kinds of outreach you're doing beyond just giving flyers or putting them on the door. I'm not saying that's all you're doing, but particularly in those neighborhoods I mentioned, that's what I'm hearing a lot of, and I just want to make sure that we are more engaged, particularly in those neighborhoods than they are.
Sure.
Thanks very much, I appreciate it.
Thank you.
Yes, and Manager Valdez?
I thank y'all for the good update and keeping us posted on what's going on. I didn't notice Montopolis anywhere. And I know Montopolis is a tough neighborhood because everybody's staying out of Montopolis. You know, I have friends who are there, and I meet that are in Montopolis. There is no, it's almost as if it's the wild, wild west. There is no policing of the constant daily, hourly break-ins that are occurring. And I know that when your team goes out and does outreach, and it may be a little bit more difficult, but when you're going into someone's home or in their neighborhood, I'm hoping that y'all are keeping track of of issues that you see for that neighborhood, for any neighborhood that you go into. You know, I say lack of parks, no sidewalks, you know, blah, blah, blah. You know, all this is infrastructure stuff that goes to build a good quality neighborhood, a safe neighborhood. Lighting, you know, are the homes dilapidated? Are there multi-families within the space of one home? Those kinds of things. You know, even if you don't you don't ask those questions, I would think that y'all have some kind of a cue for making your observations so that you can give your Yvonne and our communications team or outreach team or engagement team some cues on what's happening in the neighborhood and why there may be issues in organizing a group there. It could be they're not feeling safe to meet somewhere, you know, or have to travel, or who's going to take care of the kids. There's no childcare. You know, it's a one parent or a grandparent, or they are taking care of the family kids and feeding everybody, and there's no time. So those kinds of things are also important. It would be like what a promotora is supposed to do. But I know y'all are outreach and engagement, but all of that to me crosses, it intersects. You know, you're half social worker, half, you know, resource provider, half this, half that, you know, got a million halves. But you need to be able to do that in order for Central Health to get a good picture of what our community really looks like and what it really needs for that area. And Shannon, I thank you for bringing attention to the fact. I was looking at the staff specifically, and when I've looked at our demographics for who our patient population is or our targeted population, I thought there should at least maybe be another African American at least, and maybe an Asian. I have no idea based on the numbers. I'd have to really look at that for the poverty populations, but at least not necessarily equalized, but representative of the demographic that we're supposed to be serving. So that's all I wanted to say, but I do appreciate everything you're doing. And I was very glad to have attended the Latino conference meeting yesterday. It was very productive, and thank you all for your input.
Thank you, Manager Rutherford.
Yes, Manager Matwani.
Also want to echo appreciation and gratitude for this team. And as a resident of Montopolis, it is easy for us to sometimes forget that the Southeast Health and Wellness Center is right on Montopolis, even though it's on the other side of Riverside. I mean, I guess people miss that light, unfortunately. But that is really an epicenter of some of the great work that's being done. And I know that I think y'all have also engaged at the new City of Austin Rec Center in the Montopolis neighborhood. And I know on this report y'all listed Montopolis as well, and I appreciate it. I think if we could multiply this team person power wise, by many multiples, and make sure that we could inculcate all of the cultural competence that we wished were there, I know that we would, so we can cover all of the gaps in Austin. And like Manager Valadez said, it's almost as if we wish that our outreach team could do everything that promotoras would also do, and would do everything that we would expect a fully working public health and safety net system to do, but we can't. We're dealing with limited resources, and I really appreciate what y'all are doing with those limited resources. I wanted to point out, speaking of whenever Manager Valadez mentioned doing what promotoras do, I was thinking back to the community conversations, and first of all, how they were packed at Montopolis, multiple conference rooms merged together. Even at planning and development in the city of Austin, that was a packed house. Twice, like that, with just so many folks during the day, after the workday, during the workday. I'm still getting folks to show up from every echelon and walk of life. And also, while board members were engaging with community members, we were often flanked by members of the outreach team who were with us, making sure that if we were communicating with folks, that we were able to offer substantial follow-ups, and that we did end up hearing back from those community members later. And I know Isela was helping with that, and I know all of y'all were doing that. But I was speaking directly with Isela on some items, and really, y'all do serve as promotoras and promotores and sort of all-in-one community care team members in addition to your outreach jobs, and I just really, really appreciate that as well. That said, I also agree with Managers Valadez and Jones in as much as maybe not the how of whom we put on the ground. I don't want to get into the areas of maybe sort of prescribing what race or ethnicity of staffers we may need to have because of obviously the murky territory that gets us into. However, it would be great for us to maybe agree on what an outcome might be that we'd like to see, and then hear about tactics that we're working on to get to those outcomes, especially when it comes to engaging with populations and races and ethnicities and other demographic qualifiers in very particular geographic areas. So thanks, and forgive the ramble, but I'm really, really appreciative of y'all. And I do feel like we owe y'all an applause at some point, especially with all the introductions. Now's good.
Well, thank you. I want to just quickly say thanks for that call out around outcome-based tactics. I think that's a really good call out. And I also want to say that this cannot go unsaid, which is why I'm saying it now. Isela, Aida, Blanca, and Cassie are all certified as community health workers or promotoras, so they do that work plus everything else. And so it's just important to mention that whether it's official market research or unofficial market research, as you were speaking, Manager Valadez, our outreach team does do that, and when appropriate, they do team up with members of our strategy team and operations to ensure that their feedback is embedded into the larger strategy. Thank you all so very much.
Wait, I have a question.
Yes, oh, wait, yes.
Yeah. And I don't know if
Manager Kitchen, yes.
okay. Yeah, no, thank you. And I echo what my colleagues have said and really appreciate, and I appreciate you telling us a little bit about your background and yourselves, because that helps us understand you, and we appreciate that. So my question goes, I noted the slide on the number of applications, and congratulations for growing that so exponentially. That is wonderful. So my question just is, do you, I'm thinking about what y'all actually, what your process is. Do y'all target or any particular neighborhoods for increasing MAP enrollment? And do you target by house? In other words, do you go door to door and check with people to see if they're applied or would like to apply?
Do you want to take that, or do you want? There's a slide on your presentation, I think it's slide 7, that
Okay.
lists the communities. And those are communities, as Isela mentioned, that they are, they have the highest concentration of people living in poverty that are not enrolled in any of Central Health
Okay.
programs. So that's the answer to your first question, which is what area. Secondly, the team and the team can speak to this a little more granularly, but we do team up with entities, whether it's apartment complex or libraries or community centers, food pantries, et cetera, that will have where people will gather so that we can see more people as opposed to going. It's about time efficiency, right? So instead of going door to door, this team goes to where the people come and gather, people who are members of our patient population. But I'll let you speak to the door to door.
Thank you. Yes, we have not gone door to door about MAP enrollment. We have when promoting, for example, the Hornsby Bend grand opening or something like that.
Okay.
And the Snap-a-thon that was held out there recently. But working with different partners like the Eastern Travis County Library District, our team member went out to their library, which is way out in Elroy, kind of out in the rural parts, and offered application assistance there because we know that it is a distance to their nearest enrollment, and if they don't have access to internet, then it would be very difficult for them. So that's how we try to partner and extend our reach and our availability into some of these neighborhoods that are further away.
Do y'all feel that it would be, and those are all excellent efforts. I really think those are very, very important ways to reach people. I'm just curious what you all think. Would it be considered inappropriate, or would it can be considered intrusive to knock on someone's door and ask them if they're interested? I don't know. I'm just kind of asking that. I mean, that way you can reach people who don't come to things for whatever reason. And it is intensive, but, could be useful for, a one-time thing in a particular neighborhood. But I don't know if you would consider it, or if people would consider that appropriate.
Speak to your efforts.
I mean, we can certainly consider that.
Well, for Hornsby Band and for the door-to-door efforts that you guys have done, most recently for the Health Champions program in Colony Park, just speak a little bit about some of those experiences where people are receptive to opening doors, et cetera. I know when I've done it, that hasn't been the case.
Yeah, the majority of people were not very receptive to us, coming to the doors. We did start off with knocking at doors, bringing the flyers, and then we continued on without knocking and leaving the door-to-door flyers because
Okay.
of how receptive it was during the day.
Okay.
So I guess the receptiveness, and I'm going to speak from my own experience. I don't have a sign that says no soliciting, but I also, I don't know, someone coming to my door, it feels like someone's trying to sell it. So,
Okay.
I think.
So have you left literature on the door about MAP?
C2H?
Yes.
Yeah.
Yeah, have you done
C2H
that?
does.
Door drop?
Correct.
Have you done that?
Yes.
Can you tell if that gives you any kind of, can you tell if that's useful? I don't know if you can,
We can
actually.
bring back analytics. So we've done that in the past with QR codes.
Yeah.
And I know QR codes have become more relevant since
Yeah.
the pandemic. Also, people have to have internet access to access QR codes, so that's the only way that we can track it.
Okay,
So we can.
Another thing we could possibly track after doing something like that is working with our eligibility call center to see if there's a spike in calls afterwards. So that's definitely something that we can explore.
I'm just curious, I will leave it to you all whether and how to incorporate something like that, because you know what the whole scope of your work is. But I'm just curious if that helps, because it's always hard to reach people that, for whatever reason, don't go to events or can't go to events or whatever. And just wondering if that's another tactic that might be helpful, so, okay.
So we usually employ a multifaceted, multi-channel tactic
Yeah.
approach, right? Grassroots, or everything. When we've embarked ourselves on a campaign, it's multimedia, including grassroots outreach, so we can reach a broader audience.
Okay, thank you.
Manager May,
Oh, yes.
Yes, Alicia?
if I may?
Yes,
If
manager,
this is
yes.
appropriate time?
This is
Thank
fine,
you.
thank you, yes.
Yes, of course, like everybody, I'm grateful to your efforts and your work. I think that you certainly have very much been focused on your outcomes and your delivery of your objectives. But with that said, I've got a couple of comments that were really inspired by the dialogue from my peers. So if I rattle a little bit, just kind of bear with me, follow my thought. Following up on our chairwoman's kitchen's comments about going into some of these neighborhoods and doing door to door. Couple of comments on that. One is, have you attempted, and maybe you have, but I'm curious, if perhaps in some of these neighborhood complex, apartment complexes where people live, where there's a larger group of people that perhaps are lower income that may qualify or may fit our demographics for our services. Have you attempted to do some community events like in their actual community center, where they have, a little center where people come to their, do their little birthday parties or whatever that they can do. Have you attempted to do anything like that? And so that way, if you're doing that, maybe that might give you a better yield for that door to door, or it may make that door to door easier for you to get to that door to door if you've already attempted to do that, because then they become a little more familiar with your work and what your product line is, et cetera, et cetera. So that's a thought on that point. The other point that I've got, and it was sort of spurred by Manager Mawani's comments, and I'm going to take it just a deeper dive on that, because like you said, it's kind of a slippery slope in terms of how we begin to approach some of these other communities. But I'm curious about our Vietnamese communities. And I don't know to what degree that community, it doesn't just have to be that community, but they come to my mind. To what degree does that community potentially fit our demographic in terms of our income and the lack of insurance and so forth? So I'm just going to throw that out there. And if you don't have a response to that, I appreciate that today. But I would like to learn a little more about that moving forward.
Thank you, Manager May. So per our demographic report, and I'll let our strategy folks correct me, but since we were having a conversation about this yesterday, I think I have the information fresh in my mind. But in the areas where the highest concentration of families living in poverty are across Travis County, about 1% of the population speaks Vietnamese. Again, correct me if I'm wrong, but that's from our conversation yesterday. And so that's 1% in areas where of highest concentration of families living in poverty. So while that may come across as a small percentage, it's significant given the fact that that we're speaking about areas where the highest concentration of families living in poverty live. Having said that, we have been to deepen the answer to your question. We have been making more and more strides into doing outreach in the Vietnamese communities. Last year, we did a language access assessment with a vendor, and that really helped open the doors to many of these communities, non-English speaking communities. And so there was a lot of appetite from these communities to be more involved and hear from us more and more. So our team is in conversations about how to better partner with these communities to deepen our outreach efforts in these communities. There already is a lot of effort with outreach into these communities, but we want to deepen that outreach through partnerships. So that's that. And then to your earlier question, the answer is yes. We have and we do continue producing events, community events in some of these communities, including Hornsby Bend, including Colony Park, Pflugerville. It's especially easier, well, I would say it's more accessible for us to create these events where there's already a presence, central health community care presence. I understand that when we're trying to build a presence, for example, in Hornsby Bend, well before there was a health and wellness center, we were out there we had a barbecue, summer barbecue event a few years ago, and to create awareness of central health and that we were bringing a health and wellness center, right? So yes, when we're trying to get into communities, we're also creating awareness, building community events and awareness that way. So I hope that
Okay,
answers your
thank you.
question.
Do you do, I think she was mentioning events in apartment complexes?
Yes.
Do you do that?
Correct.
The apartment complexes that are run by Foundation Communities, our outreach team has gone there on food distribution days, and that's usually where the people who would qualify for MAP would gather. Yeah, we have a good relationship with Foundation Communities.
But what about the neighborhoods, in the neighborhoods or in the areas like, out there by Breaker Lane and in, North Austin? There's, these large, low-income apartment complexes that are out there. They're not run by Foundation Communities. They're either a HUD, for lack of a better word. I know it's not HUD anymore, but it's one of these subsistence programs by the housing authority, one of the housing authorities. And they're large. I mean, we're talking about, these are units that maybe have about 800 people living in these communities. They have these community centers within them that are part of the neighborhood. That's exactly correct. That's what I'm talking about.
Right, we have gone out in the Runberg area. I live there. I'm very familiar with the community. I'm involved with the Runberg Alliance, where we do events twice a year. I'm also part of the St. Vincent de Paul Society, where we go and make home visits to people who reach out to us for help paying their rent and electricity, and I always ask what they do for health coverage, and we've found a lot of MAP members, potential MAP members that way. So yeah, we are deeply embedded in the Runberg area up north, because I'm there.
Thank you.
Chair, may I?
Yes, Manager Jones, yes.
Okay, I agree. I think you have done, as I said earlier, a fantastic job. The Runberg area, I think you especially, and other areas as well. But the area I think Manager May was talking about, are you familiar with Harris Branch apartment? That's an area that has a large number of persons who would qualify. A sizable number of them are African Americans, and that's the type of community I was talking about. I'm just one of many, all up and down Dessau Lane. We focus on Runberg and North Lamar, and that's great. But the other side is I would encourage you to look at that. The other place is, I still think we need to look out in the county, outside of the city of Austin. Are you all familiar with the community of New Sweden? Community of Seal? These are communities. These are communities that are not as large as the inner city, but they have a nice number of particularly seniors and other folks who may qualify for our services. So I'm just saying that we probably need to look at, and I'll be happy to meet and talk with you all as a demographer. That's one of my areas of interest in seeing. These are pockets that will ultimately be the new suburbs because those folks are being moved out of town. So that's all I'm saying. Let's try and be more targeted specifically in some of those, and some of us have those expertise in giving you those references.
And one more last point, if I may, because I intended to say it and I got caught up in my own comments. I did want to acknowledge that we certainly, when we're talking about going into these neighborhoods door to door, or just kind of doing a deep dive into these some lower income areas, I certainly want to acknowledge that safety is predominantly the first and foremost issue that we want to make sure that all of you feel comfortable with, right? Certainly don't want you to go knocking on doors and feel like you were threatened or you got scared, you didn't like what you saw when you opened up that door, whatever. I just want to comment on that because I know that that's something that has to cross your mind from the minute you're parking in that parking lot, that you're walking over to, building C that happens to be two big buildings down from where your car is. That could be potentially something that you're concerned about. You're thinking twice, So I do understand that. And I know that this board would never want to put you in a situation where you felt either compromised or unsafe.
We would never go out alone. We have done home visits. We always go out in pairs. And the most dangerous situation I've been in was being chased by dogs.
Totally.
Thank you. And Manager Valadez?
And last but not least, again, I can't thank you all enough for the work that you do, your whole team, including Christian, who couldn't be here. And Aida, I know your training, so I have full faith in you and your peers. But I really am, I mentioned Montopolis because I know people will say and try to associate Montopolis with Dove Springs, but they're very different communities. And let me tell you, a lot of concentration goes on Dove Springs, and Montopolis goes by the wayside. And that's the only reason I'm telling you that, because it's really bad. I know, it is really bad. I used to live, for all intents and purposes, there, day in, day out, and it's over Latino, and it was really, it's gotten worse. So I just want us to not lose sight of that, and also use Allison. Allison is a great resource that you have IDEA there also. You have that apartment complex. It's a subsidized housing complex. It's right there where the light is on Metropolis, across from the Dollar General or whatever. That's a big complex too. And then you've got the ones that are on the other side going towards 183. Those are all good. And also don't forget, you still have the church is right there. So, and they have a meeting hall. They have a pastoral center. You could talk to the priest and see if you can maybe do a Saturday morning meeting and put some information out. Use the staff from Allison to send notes home in the backpacks to their parents who live up and down Vargas or Felix or back in those neighborhoods. It's just, there's a lot of fear because of, somebody's sitting there shooting up and they have 1 million needles in the driveway. It's just really hard for anybody to want to get out and go. And I don't know when the last time y'all were there in Montopolis, but there are so many neighborhoods like that in the Eastern Crescent. Thank you for bringing it up again, Shannon. But thank you. I'll send you all more information. Thank you.
Please do. Thank you.
Thank you. Thank you all very much. It was great. Thank you. All right, so no motion is needed on this item. So number 3, receive and discuss an update on the Black Men's Health Clinic, and Monica Crowley, John Morgan, and Tara Trower will be presenting.
Madam Chair, if you don't mind, could Larry join them? Larry Wallace, please.
Oh,
He doesn't
No.
want to?
no.
Because I have some questions specifically to him. Anyway,
Okay.
thank you.
Yes.
A point of information. So is this a report on the Black Men's Health Clinic from Central Health, not from the Black Men's Health Clinic?
Right, I think.
Yes, I think that's right, yeah.
Which is a message in and of itself, I guess is what I'm implying, but
And
that's
the
another
message
point.
for me is that I want to hear what Central Health has to say, but I want to hear, more importantly, what the Black Men's Health Clinic has to say.
Thank you, yeah.
So you not want to hear from the staff?
Presentation, because I think typically when we're staff and staff from Community Care and Central Health Enterprise Partners make presentations to the board, and I think that is in fact what we are posted for. So,
Yes, that's correct, yeah.
All right, so it's on. So thank you very much, managers. Very pleased to have been invited to speak with you today. This is sort of, in some ways, sort of our annual report on the updates on what's going on at the Blackman's Health Clinic. I will say that most of my report is going to be focused on the clinical care component. And I'm sure that you all have questions about the outreach, and I'll speak some to that. And so happy to answer questions as we go on. So first, just sort of a general summary. Thanks to the money that you all provided, we were able to hire a full-time provider. It takes some time to onboard these things, and so he did not really get started. His name is Dr. Taylor Jenkins. He comes to us. He received his medical degree from UTMB. He's actually a Longhorn. He's a UT Austin grad for his undergrad. We did extend the hours as directed starting in January of 2024, but we're only able to do it with float providers, which really doesn't give us the ability to really stand up a practice and grow a practice, particularly with such a vulnerable patient population as this. And so we were very glad to have him on. He just finished his third full month. He was going to come speak tonight, but he has a panel of patients that he needs to see this afternoon, but he wishes that he could be here. The clinic is currently open Monday through Thursday. It's still 40 hours. What we did in listening to the feedback and sort of patient trends, it allows us to be open from 7 a.m. to 6 p.m. And we have a very strong relationship with our other clinical sites at Runberg and others that can handle needs that can't be met at that location. Additionally, very recently, we were able to work out in coordination with Central Health, BMHC, and Integral Care. There is a full-time behavioral health provider who works in conjunction with the community care psychiatrist under the direction of our CMO, so that there's the ability to escalate needs as necessary if they go sort of above and beyond sort of general behavioral health needs. And so we're really excited to see that take off. Next slide. So just as a refresher, I updated the timeline slide. You know, this is a project that we've been working on in collaboration with the Blackman's Health Center since 2022. And we continue to keep an eye on how things are going. As with our other clinical sites, which actually I'll speak to you about next week, growing a practice takes time. Generally, it's an on-ramp of about 12 to 18 months. And really, for us, really starting the clock from when we have that permanent provider and that team around them on board. The unfortunate thing, and you can go on to the next slide, is that June and July are typically our slowest months, and so it's really difficult to make any real assumptions of how things are going. And so you see the number, when we pulled the numbers originally, it's about 44% of clinical capacity. Some of that has to do with no-show. They are certainly booking more appointments than that. We are still struggling a bit with the no-show rate, but working very hand-in-hand with our partners on the outreach team at BMHC to try and fill those slots in real time and working to work in walk-ins. There are some questions about, well, is it the building? We do have a slightly limited scope of service because of the building that is at. It was not built as a clinical site. There remains the question about whether or not the hours and days are right. We are not open on the weekends. We are not open on Fridays. And this is not an easy demographic to reach. If so, we wouldn't need this particular partnership in the first place. So these are all things that we are looking at, and I think in the exit interviews that BMHC is doing, and they can speak more to that, we're learning more every day. I've got a few charts on here in terms of our payer mix. Our largest payers are MAP and MAP Basic, followed by self-pay patients and commercial. It is a slightly higher commercial mix than we would see otherwise, but remember that commercial also includes ACA and some of the others. And then, of course, we have our sliding fee scale patients as well. In terms of gender, that it is about 78% male. Currently, our practice, and this is about building trust in the communities, that in some cases, folks bring their partners and spouses in as well. What we do is, if there's an acute need, we go ahead and treat them. We're not going to send anyone away. Getting to a doctor's appointment is hard enough as it is, but then we refer and make sure that we connect them with whatever their needs might be at one of our other sites, if they so choose. So I figured there was probably going to be a question about that number, so I'll just go ahead and head you off at the pass there. Next slide. So when you look at our top 5 zip codes, they are our high-need zip codes in and around where the Black Men's Health Clinic is. You take a look, North Austin, which we talked about earlier in terms of outreach and needs, Windsor Park, Pecan Springs, the LBJ High School, Colony Park area, and then, of course, Pflugerville. When you look at ages, and it is wrong in your packet, and I'm so sorry. Actually, Larry caught it when I sent him the slides this morning to double check me that a .0059 had become 59%. And so we have adjusted for that. And so you can sort of see what the breakdown is in terms of pretty good. The bulk of our patients are between 27 to 54. The reason why we kind of cut it off at 27 is that separately, community care has a separate initiative really trying to encourage uptake in services in that young adult demographic, those individuals trying to build healthy habits, get them engaged in our healthcare early before they develop these chronic conditions that have such dire consequences down the road. And then, of course, you look at patient race and ethnicity. It's not rolled up the way it is when we normally do from UDS, when we've got time to kind of combine and peel out Latino versus African American only. So you'll see, you know, although it says 49% white, a large proportion of that is our Latino Hispanic population. They do not add up to 100 because these are the top 5 categories, and so we are seeing other races and ethnicity within the context of the clinical setting. And then generally, I will just speak to the outreach activities as we work collaboratively with the navigators who are out in the community, bringing folks in, as well as the BMHC medical team that really developed a real-time connection. They're meeting weekly with leadership. The navigators are able to schedule appointments just as our teams are, and really working on that ability to deliver same-day care when it is needed. We are also working with the BMHC navigators to help establish telehealth access from Community First Village. We are there also, but we are not there full-time. They have indicated a need for additional access, and so working together, that is a project that we are working on as well. And of course, their outreach efforts, which they can speak more to, includes their Healthy Cuts Barbershop program, faith-based outreach, street outreach support groups, lots of sporting events, both sort of at the community level and at the school level, and encampment, food, and water distribution. Next slide. And so even though Dr. Jenkins wasn't able to be with us, I've been tasked with reading his comments on the work so far in the few months that he's been at the clinic. That BMHC and community care are welcoming a population that has historically been underserved, under-resourced, and seemingly undervalued. Everyone involved with this clinic, both on the BMHC side as well as the community care side, in addition to our partners, are really working to build a safe and comfortable environment for patients. And I am blessed to be able to help these men feel seen and have a chance at a quality and healthy life. And so, I did receive some, just some data points from BMHC. It does look like as we get into August, things are picking up, and so that's good news, and so we'll keep you guys apprised. I don't know if there are any specific questions for me? You're next.
If I could just add very quickly, Chair, just want to acknowledge and thank Tara and our colleagues over at Community Care for really leading this effort over the past year and a half, 2 years at this point. As a reminder, our contractual relationship for this work has been directly with Community Care, and Community Care has held the relationship with Black Men's Health Clinic. We've really had 3 components to how that works. We've had direct reimbursement for the services that community care is providing. We've had an operational subsidy or a ramp-up subsidy to help support that additional provider time so we can have an extended presence over what we had 2 years ago. And then there's an outreach component that Tara just mentioned briefly. Our plans going into FY25 in collaboration with our partners at Black Men's Health Clinic and Community Care and with this board's guidance is to bring that outreach component here directly between Central Health and the Black Men's Health Clinic so we can continue that work and then to sustain the efforts with Community Care as well in terms of the direct services that are being provided. So happy to answer questions, but thank you, Tara, for your leadership.
My pleasure. Thank you so much.
All right, does anyone have any questions? Manager Jones, yeah.
A couple of things. One is, thanks very much for the update and the presentation. It was very helpful. I guess when I look at this is somewhat disconcerting, and I understand it'll take time to get to where we need to go, but at the Black Men's Health Clinic, 50% rate roughly of the patients are white. Now, white, you're saying Latino.
So, for the purposes of EPIC and our health records, we take demographic information the way it is done in the U.S. Census, where race and ethnicity are split out. So individuals are first asked what race they are, and you're given white, black, etc. And then you're asked ethnicity. And so we have a number of not only white Latinos, we also have African American or Afro-Latinos and a variety of other factors. So it is, I can bring back, it's going to take some time when we do that roll-up. We typically do it UDS for HRSA to figure out what the overlap is.
Do we do that with other other FQHC clinics?
Yes.
So we have that information already from those?
Not in real time. I got the request 4 days ago.
I think it would be helpful to have that as we go forth, because with a diverse population of ethnicities, I think that would be perfect. We also have Asian African Americans as well. So I just think we need to be able to.
And we do have the yes, I can pull that out for you and deliver it.
The second question goes to what you were saying, John, with regards to FY25. What I had proposed in the budget is that we separate out, as I think you agree, the funding for the community outreach will come to Central Health. Because our expectation is that that would be then a contract with Black Men's Health Clinic to be able to do that community outreach. It'd be a contract. It would not be ran by Central Health. It'd be a contract. I just want to make sure we're clear on that understanding. I'm not saying we would not oversee the financial fiduciary responsibility of the grant, but I'm just saying I want to make sure we're all on the same page.
Yes, a contract between Central Health and Black Men's Health Clinic related to the outreach component.
Okay, then, thanks very much. I have some more, but I'll let my other colleagues go first, so I won't belabor it.
Does anybody have a question? Okay, well, we'll just, Manager Valdez.
Thank y'all. Thank you for that. I noticed you said that you have, I guess it's the community care outreach that's doing that. Is it Central Health Outreach? Who is doing outreach?
The BMHC, Black Men's Health Clinic.
They are doing the outreach themselves.
And it's hard because the site is BMHC, but then there's also the organization that's BMHC.
Okay.
And they are contracted currently with Community Care to do the community outreach and those activities that I mentioned on that last summary slide. And the proposal that Manager Jones and we've all talked about, going to shift that contractual relationship to Central Health instead of just us being a
So
stopgap.
I'm curious as to how is that working and how are they following up with no-shows? Because that was, I know no-shows is always a problem, especially when you're getting into your minority communities or people of color communities, because they have historically not wanted to go to the doctor. you know.
We have made great progress in terms of establishing a workflow that works for getting those no-show ends. And that was sort of what I was talking about with regards to June and July not being great indicators for our first few months of a full-time provider, because those are just bad months across the system, and they are every year. And so the process is in place. We've worked out the kinks in real time. It was working great in the spring, and I fully expect that we will see that ramp up again in the fall.
I appreciate that, thank you.
Yes, Manager Matwani.
Just kind of carrying on with that question, and I can appreciate, of course, the demarcations of all the different scopes of work and different duties and competencies that each of the appropriate, or I guess respective organizations has. That said, sort of reaffirming clarity on one of them, which is when it comes to no-shows, it sounds like of course, we're all together when it comes to solving for these outcomes, right? But when it comes to the specific duty of sort of tackling the no-show issue, following up with no-show patients, finding the reasons, reincorporating those reasons into our workflow. And I know that we already have a sense of a lot of these reasons and causes, but nonetheless codifying that stuff and continuously improving it, but reaching out to no-show patients, getting them to show, if that is even a remedy. Is that the purview of Black Men's Health Clinic outreach team, or is that the purview of community care direct staffing?
It is a collaborative partnership. We have a community health worker as well, and that's why I said that in real time, so their navigators have some of the same permissions as our community health workers. And so, for example, if they are out in the community and they identify someone who wants to be seen today, and we have no-show rate and we have capacity, they have the ability to get that individual in real time. To your point about follow-up on folks who just cancel, this is something actually that we've instituted across the system, that we are now proactively reaching out. If it's appropriate, do we switch that person to telehealth so we can get at least some of their needs met, get them back on the schedule, and understand why, and that's why that community health worker is so important, what the reason is. Is there some other social determinant need that hasn't been met that we need to connect them with another resource to? Do we need to reschedule them? Is the location not convenient? Do they need transportation? And that's where we get into those things. So that is very active, and it's a two-part process depending on where they've come in.
That more profound, well, in my opinion, or at least on face, profound sort of workflow when it comes to, okay, do we need to evaluate something deeper? Is there a social determinant or a non-medical driver that we need to look at? That is, it sounds like it's the workflow of community care staff, largely, right? Okay, and the reason I'm asking these questions is as we go forward and we see of course, as we're all hoping for, continued growth and uptake and utilization of these services, you know, what are the checkpoints we want to see along the way if we're maybe not seeing that rate of growth as quickly as we want, right? Or that we're not seeing the rate of utilization get to where we want it to go. Whom do we assign that accountability to? And maybe what is our goal? What is our goal when it comes to no-shows? You know, even if it's abstract, like what's our starting goal, right? Because, you know, we're at this a year and we're going into a new budget year. So what is our goal, or whom would we ask for that goal? And then who owns that accountability, or how do we assign that accountability?
So I'm going to talk to you a little bit more about this next week when I come back and talk about all of our new clinical sites. One of our organizational priorities for this year is to reach 75% utilization at all of our new build sites, and that does include Hornsby Bend, that includes our new Pflugerville expansion site, that includes Chalmers Court. More to come on that next week. But it also includes the Black Men's Health Clinic. And so I would say the others who have been open longer at their full capacity have reached it already, which is why I say it's really too early to tell, that we need to give the provider an opportunity to really build the practice, establish trust. But it's really, yes, no-show is important. With this population, you are always, always, always going to have no-shows. And so really it's what other strategies do we put in place, whether or not it's the transportation that's provided or other things, to get folks so that we can work them in? Do we open up walking capacity so that we are fully utilizing the provider? And then that becomes a success. And hopefully as they establish trust with the provider, some of our strongest providers who always get rave reviews, they have lower no-show rates. And so it really is a process. But with this community, because one of the reasons why we've established this practice is because trust is so low, it's important that we work with the community partners because they can help build trust in a way that we cannot.
And I do appreciate that. I mean, and still, indicators are indicators, right? So, I mean, I guess like no-show, granted, I don't think anyone's going to expect a sort of a miraculous sea change because we're dealing with a residential population of our neighbors who have a lot of reasons not to be engaged with our mainstream healthcare system and even the safety net healthcare system. So it makes a ton of sense. Not to mention, of course, the access barriers that are in play, that are systemically there, that no-shows would be where they are. But could there be maybe a trio of indicators that we may look at and a trio of respective sort of aspirational goals that wouldn't be huge, but I mean, I guess it's easy for me to say that but that would represent, okay, let's shoot for this, and maybe we can call them provisional goals. The reason is we have an opportunity, as I see it, as we head into a new budget year and we are looking at contracting directly with the Black Men's Health Clinic for a unique set of competencies and outreach services to be able to elevate whichever strategies are helping move these needles, right? And so if we can see these needles being moved, we should be measuring them, and we should at least be hopefully setting some early goals, even if they're provisional. And so, not that we need to belabor it, and not that I'm asking for those goals right now by any means.
And I do
that's
understand what you're asking. I think at this stage, since it's still a pilot, what we want to see is growth and trending in the right direction. And for us at this point, that is success. I think the challenge is until we better understand what some of the barriers are to the population, and I mentioned we're in a site that we can't do full scope of work. Are the days appropriate that as we pilot, take those learnings back to both sides of the house and figure out what works, then we can make some decisions. But acknowledging that across the country, this is a really hard demographic to reach, and so having the same KPIs as we might have at a different site or that a private provider might have, I don't know that we have enough information to make those right now. So, but I hear you. We are looking at the data every week and sharing it across the line.
Thank you. Thank you, Dr. Brinson.
Chair Brinson, it is up at the 5:30 Hasib Abdullah, County Attorney's Office. If we do have a quorum here, I don't know what Chair Kinchin and you have decided, but we are up at the 5:30 public hearing, statutory required hearing.
Well, can we wrap up this item?
Whatever
If
you guys
it's
want, it's
closed?
the discretion of the chair.
And then you can adjourn, not adjourn, you can go to recess.
Recess.
Yes, Manager.
Just really quickly, I'm one of those people that's gonna sit there and say for our marginalized communities, when you're closed Friday, Saturday, and Sunday, and you have to wait until Monday through Thursday to be seen, that's gotta be tough. That's really tough, because I would prefer at least a Saturday. Like, can we be open a Saturday? Whose decision has that been made? Was that made by the provider, or was that community care? Who made the decision not to be open at least one day on the weekend?
So the hours are still at play. I do agree in terms of full access. We don't have many sites that are open on Saturday.
That's
I'm
right.
going to use an example from my old life in newspapers, that it's very difficult to do incremental increases, particularly with an entire team, because you're not just talking about the provider, you're talking about an MA and all the support and all the things that go with it. And so once you get to 40 hours a week, being able to add is then another 40 hours a week, which we are not at the numbers right now. to do that, although we're keeping an eye on that. And so that really is the challenge that we have right now in terms of capacity with a single provider, what makes the most sense. Yes, Saturdays are useful. We still have walk-in at Hancock and other places. While it's not the same environment as the Black Men's Health Clinic, it's what we can do right now in a way that really makes sense and is good stewardship for what we have right now. But we are still experimenting to see what will work.
I appreciate that, but I really feel that I'd rather be open on a Saturday than on a Monday. Thank you.
Well, there's been sort of a suggestion that maybe we just go into recess, and if it's okay with you guys, maybe pick this back up after that recess, and in case anybody has any further questions.
We're finished with this.
Are we, we're finished?
Or did you have more?
I had one more question that I was gonna ask, so, I mean, I can wait to recess, after recess if we need to.
I think because of the time, we should go into recess because it's a requirement. Yeah. So
Are they
let's
gonna be
go.
available?
Yeah, will you guys be available after? Yeah, okay,
Okay.
thank you so
Thank
much.
you.
We'll just go into recess.
Okay.
All right.
So I think you have to call in
Okay.
recess or
So,
something. I don't know the time.
So the time is 5:32 PM, and we are going into recess for the public hearing on, yes, thank you.
Okay. All right, so good evening. Today is August 14th, and it is 5:32. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. The first item of business is the public hearing on the tax rate. So this evening's hearing is the official public hearing required by the Texas Tax Code, which we announced in our previous meeting on Wednesday, August 7th, 2024. Notice of this evening's public hearing was published in the Austin American-Statesman, was posted on the main page of the Central Health website, and has been broadcast on Travis County Television. The hearing will begin with staff's presentation of the budget and proposed tax rate. At the conclusion of the presentation, we will invite comments from the public. So we'll start the public hearing after the presentation. To make comments during the public hearing, members of the public must either be physically present at Central Health or have registered with Central Health via the online form or by telephone no later than 4 p.m. today. So item number 1 is to present an overview of the proposed Central Health fiscal year 2025 budget and its associated tax rate. And Nikki Riley will be presenting.
Good afternoon, Nikki Riley, Deputy CFO. For the fiscal year 25 budget, we are proposing a tax rate that is 6.5% over the no new revenue rate, which calculates to a tax rate of 10.7969 per $100 of valuation. So on the average taxable homestead value of $504,000, that is a tax bill of $544, which is $66 over the fiscal year 24 average homestead. Attachment A on the next screen is a summary of our budget. This increase will help provide $347 million of property taxes. 88% of our revenue at Central Health consists of tax revenue. And then our available budgeted resources with our reserves would be $884 million. Our complete proposed budget for fiscal year 25 is on the Central Health website at www.centralhealth.net. Go to About Us tab, and then under that, go to Finance, Budget, and Tax Rate, and it will have all of this information.
Okay. I know that at least one of our board members had a question they wanted to ask about the budget. So I'm going to recognize Manager Valadez first, if you still have that question. You're going to go last. Anybody else have a question? Now, again, you know, we vote on the budget next week, and we've also had a lot of conversation about the budget in previous meetings. So today, it's just if you have something that you need to ask that you haven't asked already about the budget. Anybody have anything?
Well, we're talking about the tax rate right now.
The item is the Central Health fiscal year 2025 budget and its associated tax rate.
Okay, so it's both.
So, okay, I'm not seeing any other questions. Manager Valdez, do you want to ask your question?
Yes. With respect to the Latino
Yeah.
conference, I was curious as to whether or not I couldn't get complete clarification. I just wanted to make sure that there had been in the 2024 budget, there was 125,000 allocated for the planning of that conference. And then there was going to be for the 2025 an additional amount allocated because in the meeting that we had yesterday, it appeared as if Sarah Hay, who was representing the consultant from Linda Rife's group, said that they were already at max on the 125,000. And so when I spoke briefly with Bedla earlier, I was like, well, what have we spent it on? Just curious. So I could know whether or not, is that incorporating the 2025 conference dollars? Or is it, because I know they've had to put out deposits and they've had to put out this and they've had to put out all kinds of other things. And so I wanted to make sure that there was an additional amount being allocated for the conference itself. And I was hoping that it was, I had been under the impression it was going to be 125 for the planning, and it was going to be 250 during the event of the 2025 for the conference to go on. Is that correct?
Yeah, so
I
what we
believe
need
so,
to
yes.
what we need to understand is what's
Careful,
in.
Jeff.
Oh, Jeff, you okay? Okay, so if I'm hearing you right, Manager Valadez, what we're wanting to understand is what's in the budget for 2025 related to the Latino Healthcare Conference.
Yeah, so, thank you, Jeff Knoll, CFO. So what we budgeted for in 2025 is $250,000 for conferences. Now, what I can tell you, I think right now is the amounts that have been spent would be in 2024. So 2025 doesn't start until October.
That's
So
right.
what we can do between today and next week is we can go back and look at what's been spent for planning and the conference cost, and then look at that, and we'll come back next week.
Okay, that'd be great if you can look that up and then provide that information to all of us. That would be great.
Okay,
All right,
thank you.
Appreciate that. Thank you very much, Jeff.
okay.
I had a question, if I may
Okay.
ask. It relates to, one, the African American Family Support Conference. I understand that there's been agreement from Integral Care in terms of amount, but that was not the amount that I had originally put forth. And I didn't know, is there any reason that we decided to curtail it other than, and I want to make sure I'm clear, that Integral Care said they didn't need that amount. I'd proposed 50,000. It's my understanding that we might be agreeing on 25,000. So is there any reason that was reduced?
I kind of know a little bit about that. I think that we are prepared to give Integral Care what they have asked for, which I believe is 25,000.
Okay, but if, so I don't have the opportunity to request that that be higher.
I think you have, as a board member, you have the opportunity to request whatever you would like to request. I think we're hearing a disconnect between what you're requesting and what Integral Care is telling us they need. So you've got you've got until next week to clarify that with Integral Care is what I would suggest.
Okay, all right then.
Okay, all right.
I just would like to say something in addition to that, if I
Yeah.
have the ability to do so. One of the biggest, a huge conversation point or piece of the conference that we're going to be hosting in 25 for the Latino and non-English speaking or other than English speaking population was the emphasis on mental health and how much that is an overarching issue to the quality of their lives, the quality of their family lives, the children. It's just huge, and that I believe is based a lot on our cultural responsibilities to not talk about those things, not address those things, and the impact that has on one's mental health and ability for a community to come together and address issues. And so I personally, that's why I was gonna go for pushing up the dollar amounts, because it's almost like we should have started out being a mental health conference, because it seeps into every other aspect of your life, and how you're successful in school, or this, or life, or can you get a job, can you get out of bed. It has everything to do with a person's ability to exist and have a high quality of life. And so I'm really concerned about.
I think we can all agree that mental health is an important part of the Latina Health Conference, as well as the African American Health
But
Conference.
my comment was about the African American.
No, but it's not only that. That's why I was saying with this,
I
it's
think
not
we're
just
all in
Latino, but it was
agreement.
African American also. It's just,
Right.
I think we're all in agreement, and
economic
Manager Jones,
stress.
we've got some time to figure that out, and so we'll figure that out, and I'll be happy to help you with that between now and next week.
Well,
So-
I'll get back with you on
Okay.
what I've, in the conversation with them.
Okay, I'm going to move on now to item number 2, which is receive public comment on the proposed Central Health fiscal year 2025 budget and its associated tax rate. Yesenia Ramos of the Central Health Communication Department will briefly cover the guidelines for the public hearing portion of the meeting, and will then call upon members of the public to comment. Once you've been recognized, please approach the podium if you're physically present, or if you're attending virtually, a member of staff will unmute your microphone and invite you to turn on your video if you wish. Please begin your comments by stating your name. There's a 3-minute limit for comments per board rule. Okay, Ms. Ramos?
Thank you, Chair Kitchen. I will now read the guidelines for this meeting's public hearing. When called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please, I wasn't supposed to read that part. Sorry about that. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure the efficiency of the meeting, once we have let speakers know their limit, we will allow 30 seconds to wrap up before they are asked to stop. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items for this meeting. The board may choose to set aside any other issues for discussion at a future meeting. We received 4 submissions for this evening's public hearing. At this time, I will call on our first speaker, Mr. Larry Wallace Sr.
Good evening. Thank you for allowing us to have comment at this time. And there was questions at the last presentation, and we'll have a chance to address those. So I just want to say thank you, first of all, to the board and to each of you for your support that you've shown the Black Men's Health Clinic. I also want to thank Community Care, who has really taken the lead and served as our understudy for this project. We need both in order to be successful. I'm very pleased with our progress that we've made. Thanks to you that have come and visited to see what we do. It's really about establishing trust, and that's what we do best. And as we establish those trusted relations, we're able to make an impression upon the community that we serve. Thank you for supporting mental health in the last budget session. Because of that, we were able to jointly hire a mental health therapist that's at our clinic every day, and that connects with the psychiatrist that Community Care provides on Wednesday. So it gives us a great complement of mental health, and we recognize that that's a huge pillar. Our 3 pillars are mental health, physical health, and health screenings, and social determinants of health. There's much we could say, but we're going to be meeting with the Central Health team to work out the details, since we'll be privileged to have a direct contract with Central Health. And so we're looking forward to that. I think John and Monica and the team have already expressed their support and excitement. We also want to provide our proposal on respite care that Dr. Lee came out. We didn't forget that. And so we plan to bring a proposal that we can participate in that space. So I know I only have 3 minutes, so I don't want to violate, but I just want to say thanks. And from our team, our staff, our board, we could not do this work without you. And so we believe we're making an impression, and with community care by our side, we are very, very optimistic. What we want to do in our next year is to solidify our staff. We have people on 990s, and we want to put them in a position where they feel secure. We have great people who are out there on the front lines doing the work. And so we keep getting approached by people like ACC, workforce development. Students want to come through. So we'll share all that with John and Monica and the team, because when we make our request, we're going to be asking that we can expand into Pflugerville, into Manor, into Elgin. We've already had those conversations with city officials, and they're asking for us. And so what we say, we can only go as far as you allow. So thank you.
Thank you very much.
We did have one community member who signed up that may have had a last-minute emergency, but I will just call on Sonia Burns. If you're online or here in person, I don't see you. Sonia Burns, if you're online, can you please unmute? Okay, I don't believe Sonia Burns was able to join us tonight. Up next, we have something that I'm going to read to the board. It was submitted on our portal from Teresa Perez Wisely. Board of Managers, please support funding for the Latino and other non-English speaking eligible Central Health Population Health Conference, proposed by Cynthia Valadez Sr. And so that was the end of Teresa Perez Wisely's message.
Okay.
And last but not least, I'll call up Cynthia Valadez.
She already spoke.
Okay. Then that concludes this portion of our public hearing. Thank you.
All right, thank you very much. Okay, I thank you all, and thank you, Mr. Wallace, and others for their comments. I'm now ready to accept a motion to close the public hearing. And there's a motion sheet, I believe, for that, if someone wants to make that motion.
I move that we close the public hearing.
Okay, second? Second. We have a motion from Manager Valadez, a second from Manager Brinson, to close the public hearing. All in favor? Aye. Okay, the public hearing is now closed. At this time, I will close the public hearing of the Central Health Board of Managers regarding the fiscal year 2025 tax rate at 5:49 p.m. And so, as the chair of the Central Health Board of Managers, I announce the board will be voting, I think we mentioned this before, will be voting on the proposed tax rate in the Board of Managers meeting next Wednesday, August 21st, 2024 at 4 p.m. or immediately following the Central Health Executive Committee meeting here at the Central Health Administrative Offices, 1111 East Cesar Chavez, Austin. Okay, now we can, I think what we will do at this point is recess the Board of Managers meeting so that we can turn back to the Strategic Planning Committee meeting, and then we'll come back after that. So, David, I think I'd just say we are now recessing the Board of Managers meeting. Okay, get back to you. 5:50. At 5:50.
And we're going to come out of recess on the strategic planning meeting and continue our discussion with the Black Men's Health Clinic. So think of your questions. And it is 5:50 p.m.
Okay, thanks very much. I just have a couple of other questions. I think you've answered all of those that I had with regards to Central Health relationship with community care and the Black Men's Health Clinic. And I don't know if you all can answer this, or is this a question Mr. Wallace might need to answer. Are there other services that are either provided in kind or in concert with the Black Men's Health Clinic, such as behavioral health or other items that you all are aware or not aware of that are not reported to you all, to give a bigger picture of what this clinic does. Because basically, the understanding is that you all provide the clinical services, which I get. They're doing the outreach services. But are there other clinical, i.e. mental health, or other services that might be provided by other agencies that help support this operation? And I know it's something you all may not be able to answer. That's why I was hoping Mr. Wallace would be available to join in on this discussion.
So yes, Black Men's Health Clinic is a separate nonprofit, and they can, which is why I really allowed them to speak to the outreach as well as the other services that happen in that space. So there are other partnerships, there are other services that's part of the model. And so I know that they do exist. I cannot elaborate on what they are because my information may be out of date.
Is it possible that we could ask Mr. Wallace to join us at the table to answer that question?
I thought he did tell us earlier what he was doing, right? Is there more he wants to add?
Mr.
Could
Wallace,
you give
would
a
you?
comprehensive approach of all of the services you're all providing?
Yes, please.
Stay here.
That's a big stay.
Thank you. The services that we provide are the same scope of services that community care provides, with the primary care, the health screenings. When it comes to the mental health, we partner with Integral Care, and I mentioned previously that we have a jointly funded position for a therapist, and that connects with the community care resource in that space. So other than that, there are no other different services that is provided on the clinical side. On the non-clinical side, that's a different story. You know, it's about the navigation and the care coordination and the work that we do that goes beyond what we call outreach and engagement. The work we do in that space is what was addressed earlier. How do we shore up no-show rates? Our people call in advance. We call the day of. If you need a ride, we make sure you got a ride, and we follow up afterwards to make sure you got what you needed. And it's more like case management, quite honestly, than anything else. And so that's to keep the pulse on the clients, make sure we know what they need. It is a difficult population. It takes up to 3 contacts just to get them to come in. So it requires more, but we're also realizing that we need to develop metrics for our work that demonstrate value. And so that is high on our list, and we'll be talking to John Morgan. We've already had our first meeting about how we can go about that work.
Okay, I just want to make sure that as we go into this new year, if we agree on the contract that has been put forth, that there is a delineation in terms of how the contract will operate, but that there will be consistency across the board in terms of services, in terms of referrals and connection, outreach. They understand what you're all doing, making sure you're getting those no-show numbers up and the like through your mechanism. Just to make sure that's the case.
No, I appreciate that. And as you know, we have multiple partners that we deal with. We are really a major referral resource, quite honestly, for these men, because no one agency provides all the services. And so that's why we have those MOUs in place so that we can connect. We leverage publicly funded organizations first because we're all trying to accomplish the same thing. And so to your point, and we'll be talking to John, and again, community care is right there and providing guidance for us.
Okay, then, thank you.
Okay.
Thank you both.
Any further questions, managers? No. Thank you so much, and we're looking forward to hearing you at the next meeting.
Thank you so much for having me. It's always a pleasure.
Thank you. All right, so no motion is needed for this item. And next, number 4, we're receiving an update on jail services, including enrollment of jail inmates into Central Health coverage programs. Again, Mr. John Morgan and Monica Crowley will be presenting.
Thank you, Manager Brinson, Monica Crowley, Central Health, and John and I are very excited to give you this progress update on in-mail health and jail diversion services. If you notice, it's using the kind of red, yellow, green format that we brought to you as part of the update on the 2024 strategic priorities. And so I hope that we'll be able to adopt the same type of format that kind of at a glance shows folks where we are for other programs and projects that we are working on now. We're going to get straight to the progress update part of this, which if you look at is on the right-hand side. And I think you guys are aware, because we've mentioned this to you before, we have successfully implemented one specialty care line for within Central Health specialty clinics for inmates. And I think this is something that is kind of becoming a repeat story. The first patient that came from the jail to Central Health for podiatric services, they discovered something that was going on in the foot. Alan could talk about it better, but there was something that was causing there not to be enough blood flow to the toe. It was at an acute level, and they were able to immediately take that person to the hospital and have surgery on that person's toe that was able to save their limb. So, I mean, I think this is something that's really important. It seems like every time Central Health opens up a direct practice service, we are coming back to you with a story of a life that has been saved. So that was the case here as well. We are in process, if you look at yellow, the goal of implementing additional specialty lines before the end of fiscal year 2024, so before the end of September, is yellow. I believe that Central Health's first directly employed cardiologist has started. Yes. This month. And we are hoping to be able to, that is the next service line that we would like to offer to the Travis County Jail patients. So that is quickly upcoming. And also we are offering palliative care services for people who are in the jail. Those haven't started yet, but they are quickly on the way. We also are continuing to work with local methadone providers to ensure that we can keep people, if they come into jail, if they are receiving methadone, to make sure that we can continue their methadone instead of having them weaned off the methadone. It's a really high-risk time when people are released from jail. If they've had their methadone discontinued while they're in the jail, they get released from jail, and there's a really high risk of overdose during that time period. So it's really important for us to work with the jail and the community methadone providers to make sure that that methadone treatment can continue while someone's in jail and upon their release. Another really exciting thing that is in the green zone here is that Central Health staff are providing 2 MAP enrollment classes a week at the jail. They are doing this remotely now, and since the start of this year, not just from these classes, but overall, we've enrolled 500 people from the jail into the MAP program. And as we're kind of expanding these services and starting to do them directly, we're just learning some of the challenges that folks have if the room where the class is being provided, if something happens and it's on lockdown, and that's during the time that people have signed up for the class and that class is scheduled, then with that class, that room is used for a multi-purpose area, and so then, we have to wait until the next class for folks to come, and so, we're continually learning from people at the jail, and also trying to figure out what are ways that we can provide more classes, provide more access. And also, one of the areas that is in the red is really to try to be able to enhance access to HIV or hepatitis C treatments for eligible inmates while they're in the jail. This is just something that, we have to make sure that we're following HRSA requirements. This is something we have to do with community care, so it's a little bit more complicated. And it's not as likely that we would achieve that by the end of September, although it is something that we are still kind of diligently working towards, because that's something that our partners at the jail have said is very important. It is a very high need for them. The next three areas are more about the jail diversion services pilot. So this is, all three of these are green. Integral Care has begun providing the expanded hours and expanded services at the Psychiatric Emergency Services Department that's being facilitated through the diversion services pilot work that Central Health's participating in and funding. We are participating in the diversion pilot work groups and steering committees. We actually have a meeting coming up tomorrow as part of that work. And then we are continuing to do joint planning with Integral Care on the mental health continuum of care and how this broader diversion services work fits into that broader continuum. John?
The only thing I would add is, this has been a big learning experience for us. And I think also with our colleagues at the Sheriff's Office and the staff at the jail, working in the clinical setting there. Monica mentioned some of the specialty services that we've prioritized, and we're intending to expand our services to cover all of the specialty services that Central Health is standing up, but we're also trying to be responsive to the highest need areas that the jail staff have identified for us. So we'll continue those discussions, and I think the other big observation that I would just share for awareness is, there's obviously a significant amount of complexity that goes into providing healthcare for inmates, and one of those complexities is the transitions when individuals are leaving the jail. That's probably one of the biggest challenges is the folks at the Sheriff's Office often have little or no notice that someone's going to be released, which can cause a lot of problems for, we were talking about no-shows in a prior meeting. We really want to make the connections with inmates as timely as possible, so that we don't schedule an appointment and then someone's released and then they're lost to follow up in the clinical environment. So we're trying to prioritize access for inmates in our environment. So as soon as the need is identified, we're trying to get patients in that next day or within a few days based on the availability of the Sheriff's Department to transport them. So it's a very collaborative and very dynamic environment, but grateful for the partnership with the Sheriff's Department.
Yes, Manager Valadez.
I've had quite a few people come to the house and talk to me and call me on the phone, sometimes crying about the situation at the jail. Those that have been put in the jail, and I talked to Cynthia Brinson briefly about it. I asked her whether or not it was true that if you're supposed to be getting medication at the jail, that you have to pay for it if you have any money in your account. If you don't have any money in your account, you don't get your meds. And I don't know that that's true or not. What I'm going to say is this, that there are people who are going into the jail that may not be literate, may not speak the English language. And you have one person checking you in. That person is, I'm sure, not multilingual. And so if you don't speak the language that that one person is supposed to be checking you out to make sure how you fit physically are or whatever, there is no communication. And so there is a lot of question in my mind as to what is the real process of what's really happening at the jail. What's the process? You know, you get brought in. Who's supposed to be checking you out? What does that entail? Do you get sent? You're assigned to a cell. You get your sandwich, your chips in a Ziploc bag, and a drink. Nothing else. Never and no holidays, no nothing. No turkey and dressing. Sorry, people. No tamales. No nothing. It's just you get a sandwich. You get your Ziploc chips and a drink. If you have any money in your account, your jail account, you can buy stuff in the commissary. If you don't, or if you even know that that exists, as I'm saying, not literate, not understanding a process, not speaking the language, how are you going to ever know what is available to you, what you need to say? Are you sick or not? Who's communicating that to you, and who are you communicating that to? Okay? I was told by many people that that is in fact what happens at the jail. That's I know of one person. I know that person. He was in there for a period of time. He lost so much weight, he didn't realize he was a diabetic. When he got out, he died within a month of being released from jail. And I spoke to his widow. And it's very hard to hear those kinds of stories and think that we are doing everything humanly possible to ensure that they're being taken care of in a necessary way for them to continue to live. I'm really concerned about the medication issue. I'm concerned about the account issue. So what happens if you don't even know you're supposed to have an account or that that commissary exists? You know, it raised a lot of questions in my mind as to then, in my head, I was like, well, how do we make it, and I know that it may not be, but with our partners at the Travis County and the City of Austin, how can we make sure that for people coming in to know that they can have an account so that they can get things at the commissary and make sure that each person has at least $10, $20 in their account so that that's something that they could access for additional items. But more importantly, the medicine issue and the assessing, the medical health care assessment that should be occurring, like Cynthia stated to me, you know, you're supposed to be triaged when you come in. Well, you come in late, nobody speaks the language, you don't speak the language. What good is that? You're just going to go sit and rot in a cell until something happens. And I had been getting phone calls from out of the county because there had been a period of time when at least 5 non-English speaking inmates died within a relatively short period of time that had come from Harris County. And they were very specific. They could even give me the names. So I don't think that people are making things up. And I tend to believe what I hear from a person that has a family member or themselves have gone through and experienced that.
Chair Brinson.
So I just wanted to say that I'd like for us to have a conversation about this. Yeah. Madam Chair, when we, at some point in time, and I had to say it only because that's uppermost in my mind, and I apologize for taking up your time.
Thank you. Yes, Manager Kitchen.
I have a question, and can you help me understand? I know we've only relatively recently started working with jail health services. Can you help me understand right now, what's Central Health's relationship with the county and the jail? Are we doing things on a contractual basis? Do we have a scope of service? To help me understand what the contractual relationship is, I guess. Does that make sense? Do you see what I'm asking?
I think one, and, I think.
What are we responsible for?
One of the things that we are trying to emulate is what we are responsible for and what kind of came over in the tax rate when Central Health was created.
Okay.
And the way things were done in places like Harris County before the county started to contract with Harris Health to take over those services. So typically, there's not an exchange for services that are provided in the hospital district environment.
Okay.
That we have the tax rate that funds services for low-income people in our environment. For the jail health services that are provided in the jail facilities, those are the obligation of the county, and they also have the tax rate for those services. There aren't specialty care providers and services provided in the jail, and so when people come to our facility, we provide the services for eligible people that come in our facility. If they're out of county residents, then the county would reimburse us.
Okay,
for
so
that. Yeah.
let me repeat back, so I think I'm understanding. We don't, Central Health is not providing services in the jail. What we are doing is our specialty services, which are provided outside the jail, we do make those available, so we might have someone who's in the jail be transported to our specialty clinic to receive specialty services, right? So that's the setting in which we might be providing services, but we don't provide the intake, we don't provide medications, we don't provide any other kinds of services right now, or not right now, but we don't provide any of that in the,
Other than eligibility and enrollment, when we do
for
the
when they're
remote calls.
for when
Yes,
they get out of
yes.
jail. I just wanted to clarify that. I think that I appreciate what you're hearing, and you probably know a lot about what's going there too. And I think within the scope of what we can do, perhaps we can check into the kinds of things, the medications in particular. But I just wanted to first understand what our scope was. So I think you answered my question. Oh, go ahead.
Certainly don't want to discount what you've heard, Manager Valdez, but my understanding is that the county does provide medications to inmates. I think that's actually in discussions with the sheriff's office. That's one of their largest expenditures. And I think even while we were at the jail facility touring, we saw the med distribution carts out going between the different cell blocks to administer medication to inmates. So I'm not sure what that circumstance is, or if it's a particular scenario, but I think we can confidently say that they're providing medications.
So if someone received specialty care and there was medication that our doctors prescribed, are we involved in that way?
The jail, I believe, has a pharmacy.
Okay.
At the jail.
Okay.
And if our prescribers write a script, it would be filled by the jail in that facility.
Okay.
Some of the challenges that I think the jail has struggled with is, as Monica mentioned earlier, routine access to methadone has been a challenge, and that's where we're trying to help supplement what's available within the four walls of the jail with our contracted network of specialists to provide more of that continuity. I think that's part of the item on the red, yellow, green tracker that we're working on collaboratively with community care, is trying to enhance access and hopefully lower some costs associated with HIV and Hep C drugs that are very expensive items for Travis County.
So if last question. So if one of our specialist or doctors prescribes, and the script is filled by the pharmacy at the jail, who pays for that? Is that Central Health is paying for that medication, or who pays for that?
Through the jail, through.
So the
Travis
jail would pay for that? Okay, and that's through their pharmacy. Okay, thank you.
May I ask my question now?
Yes, Manager Jones.
Given the demographics of those who go into our jail system, is there a way in which there could be a link or coordination between the Black Men's Health Clinic and particularly men of color who are going into the jail system, so that when they do get out, that there is some kind of connectivity there to ensure those who are willing to continue health care or services, that there's a connection there. Is that something that we could ask of both agencies to do?
I don't think we've explored that specifically with Black Men's Health Clinic, but there could be opportunities there and with other partners and providers. We have been in conversation with Community Care over the past few weeks to really try to formalize what some of those transitions of care opportunities are for folks coming out of the jail. Community Care is pursuing a grant specifically with HRSA around transitions for individuals that are coming out of the jail. Unfortunately, it has some limitations, but I think it speaks to the same subject matter generally. We have several service providers that specifically work with justice-involved individuals. I'm not sure to what extent Black Men's Health Clinic is focused on that population, but it's something we could certainly look into with them.
Well, I would hope that that they would be, this is a population they would be willing to work with, given the demographics of those who are going in, who are incarcerated.
Yes,
All right, thank you.
Yes. Dr. Lee.
Been reflecting on this evening's conversation and wanted to mention a couple things and maybe connect a couple dots. There have been a number of important conversations and comments, making sure that we don't lose sight of the populations in particular of color in the more vulnerable areas of our county, and make sure that we don't lose sight of the mission we've committed to understand why there is a 10 to 20 year life expectancy difference, largely on the east side, in the patients that we are privileged to serve. So I just want to first say that is our core commitment. That's why we're here, and to get deep into the underlying reasons. I also want to pick up on your point, Manager Jones, that when we talk about inmate health, or we talk about respite care, or care for people experiencing homelessness, we may not say explicitly care for people of color, in particular our Black neighbors, but that is in fact what the demographics of those areas reflect. And so while we don't necessarily apply those labels per se, we know, and we want to say proudly, right, that we recognize that is our responsibility. We acknowledge the leadership of those who've wanted us to make sure we focus on patients at the most vulnerable stage. And so when I hear 500 folks who previously were not on MAP coming out of that inmate environment who now are, I don't know if we have the exact demographic statistics, but I can assure you hundreds of those individuals are Black, hundreds are Latino. Maybe we should be more explicit about our opponents' demographics, but these are the areas where our patients are most vulnerable at those transition points with medically assisted therapy for substance use disorder. Someone tapers off and then leaves with no insurance and no MAT. That is extremely high risk situation. I don't know the race or ethnicity of the individual whose foot was at risk and was going to lose their limb and made it over to our podiatry practice and their limb is saved. But I wouldn't be surprised if that is an individual of color. And so I just want to say out loud that we are laser focused on our mission to reduce the life expectancy gap in the Eastern Crescent. And much of that pain is felt in the jail. Much of that pain is felt on the street. My colleague, Larry Wallace Sr. mentioned a question that I had asked when I did have the privilege of visiting the Black Men's Health Clinic, which centered around trust. I appreciated that shared focus when we have, there's an environment we have a little more operational line of sight to at the moment, which is our respite environment And I asked the question, if we know that a black man in respite is getting ready for a transition out of respite, would that be an opportunity for one of your outreach workers, who could connect with that individual to come and meet them before the transition point? So that's the conversation that we're going to pick up on, which is very similar in my mind to the question you just asked about the inmate situation. But we want to make sure that we are lifting up and partnering with our colleagues, Sheriff Hernandez and her team, Judge Brown and his leadership, and the county commissioners, in inviting us to really look at this situation. We want to build trust there, and we want to advance the care together, which we are doing, as you can see here on this green, yellow, and red dashboard. So as we get to that place and we can look at those transition points, we will. But I just wanted to just emphasize how important the topic is, and call out that actually in many, many ways that may not bear that exact label, that is exactly our focus and our commitment.
Thank you.
Any further questions? No. Thank you all so much. Okay. So again, no motion is needed on this item. So our last, number 5, confirm the next strategic planning committee meeting date, time, and location. Managers, our next Central Health Strategic Planning Committee meeting is tentatively scheduled on Wednesday, September the 11th, 2024, at 4 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I am ready to accept a motion of adjournment. Manager Valadez, motions for adjournment, and a second. Manager Jones, and all in favor? Manager Matwani, in favor? Yeah.
I don't think I'm a voting member of this committee.
Oh,
but,
okay. Okay.
But I'm in spirit with you all.
Thank you.
Okay, Manager May, wait.
Miss, Manager May.
She's in favor.
She's in favor. Okay, yes, thank you. Thank you.
Okay, everyone, I'm going to call us back in the Board of Managers meeting. So, because we're going to go out of recess and back into our Board of Managers meeting. So now we will proceed to the consent agenda. So managers, the first and only item on the consent agenda is to approve the minutes of the Central Health Board of Managers August 7th, 2024 meeting.
Chair Kitchen, before you take a vote, you don't have 5 people at the table. Manager Jones has stepped out, so you've lost your in-person quorum.
But we have 2 people.
You have to have 5 people in person. That's in the statute. Sorry. Yeah. Just changed from 3 to 5. And he's back. Carry on. My apologies.
Okay, so, do I have a motion on the consent agenda? Motion from Manager Motwani, second from Manager Valadez, all in favor?
Aye.
Aye. Okay. Now we move on to we'll now proceed to the regular agenda. The first item on the regular agenda is to discuss and take appropriate action on the selection of an external financial auditor. Nikki Riley will be presenting.
Hello again. On this item, we are going to request, oops, sorry.
That's okay, go ahead.
We are going to request that you take action on this item. In accordance with the bylaws, the Board of Managers is required to retain an auditor, external auditor. So we are requesting approval of the selection of the external financial auditor for Central Health as recommended by the RFP evaluation team, which consisted of members of both Central Health and CUC. The scope of this audit is a financial statement audit to make sure that we present fairly in accordance with general accepted accounting principles. That is required for governmental agencies, especially those that have gone out for debt, because we do have to report annually for that. The auditors are going to express an opinion in a formal report, and they also look at our internal controls, make sure those are sufficient, and then make sure that we're recording our transactions properly and so forth. There are some best practices that I know that Central Health has followed in the past. In accordance with accounting principles, GFOA, the Governmental Finance Officers Association, they recommend that we go out for bid, a competitive bid every 5 years minimum, and that if we do retain the same auditors in the previous contract, that at minimum, that partner on that audit is rotated off and is not a part of the next contract.
Okay.
We did go through an RFP process with CUC. They were at the end of their 5-year contract as well. So the RFP process takes a lot of time and effort and resources. And so they were okay in collaborating with us on that RFP process. And we could have gone with one auditor for them and a different auditor with us, or one auditor for both. People that submitted, the entities that submitted were allowed to do both. We did have a scoring team of 6 people, 3 financial professionals from CUC, 3 financial professionals from Central Health. The scoring criteria, number 1 for us was firm experience, and the engagement approach, the project team structure, price, of course, and then we left it optional whether we wanted to do interviews. We did have 5 proposals that were submitted. After we looked at those proposals and scored those, we felt like we had 3 qualified to go forward that were going to be capable of doing our audits. So we scheduled those interviews, and then after going through those interviews, we did unanimously decide to go with Maxwell Lock and Ritter. They did hold our last contract, and so of course, for the next contract, we'll have a different partner on that audit. Next slide. So we would, time is kind of the essence. We do want to start immediately on interim field work, especially for gathering the data that they want. We would like to start in late August or early September. Of course, we're going to begin contract negotiations just as soon as you are okay with Maxwell Lock and Ritter. And that's about it. Special thanks to CUC. We did collaborate. It was a unanimous decision. It was a streamlined process, and it was very nice to collaborate with them on this. And if you have any questions.
Okay. Does anyone have any questions? Let me check with them first. Manager May or Manager Musaitif, do you all have any questions?
No, I do not.
Manager Musaitif, if you want to go first, and then we'll go around the room.
Can I make the motion?
Oh, well, yeah, you can make a motion and then we'll take questions. Go ahead. You have to, there's a specific motion that has to be read for that. Do you have that in front of you, Manager Musaitif?
I can read it.
No, I don't. So,
okay. Okay.
Thank you.
You want to make the motion? So Manager Valdez, make the motion if you want to second it, Manager Musaitif. Okay, go ahead.
I move that the board retain Maxwell Lock and Ritter as the external auditor for Central Health Financial Auditing and delegate authority to the president and CEO to negotiate and execute a contract with Maxwell Lock and Ritter for the auditing services.
Okay, Manager Musaitif, if you want to second it?
I'll second, thank you.
Okay, questions? Any questions, comments, anybody? Manager Musaitif?
Thank you, Chair. I just want to commend staff and their collaboration working with CUC. So I'm glad they collaborated together on this contract, and I believe I had a brief discussion with Jeff, and I'm very pleased with the process. And we've had this auditor with us for a while, and I'm very pleased with their work. So I definitely support this. Thank you.
Thank you. Okay, I'm not seeing any questions, so all in favor?
Aye.
Okay. We have Manager May and Manager Musaitif voting aye also. Okay. All right, we will now move on to item number 2. Confirm the next regular board meeting date, time, and location. Managers, our next Central Health Board of Managers meeting is scheduled for next Wednesday, August 21st at 4 p.m. or immediately after the Executive Committee at Central Health Administrative Offices. At this time, I'm ready to accept a motion for adjournment from Manager Valadez and a second from Manager Machwani. All in favor?
Aye.
Aye. Okay, we are adjourned. Thank you all.
Thank you.
Thank you.